Prashant Upasani sir from Noida with us. Sir, at this point of time, now ARNI are going off patent, and now it would be access to majority of patient. So at this juncture, what you feel the right place of therapy of ARNI, and what are the precautions that the cardiologist should follow for the best use of ARNI in a clinical practice?
You know that ARNIs were introduced, I think, way back in 2016 by Novartis Group because it was the original molecule. But now, since it has gone patent, it will be widely available and at a much lower price, which is available right now. Now, the place of ARNIs as far as the heart failure management is concerned, it is definitely among the top 4 molecules. At the moment a patient of heart failure is diagnosed, in our current practice, we start therapy with SGLT2 inhibitor and beta blockers. In next week or after another 2 weeks, we call the patient back and then we switch over to MRAs or mineralocorticoid receptor antagonists like spironolactone or epinol, and subsequently we start them on ARNIs. So by the end of 4 weeks, the patient should be on all big 4 medicines: SGLT2 inhibitor, beta blocker, mineralocorticoid receptor antagonists, and lastly the ARNIs. Now, ARNIs definitely have a place in HF reduced ejection fraction, but as far as the HF preserved ejection fraction or HF MRAEF is concerned, the role of ARNI is a little questionable. Here it enjoys a class 2B indication or class 2A indication, whereas in HF reduced ejection fraction it enjoys a class 1B indication. And the important thing is, very important thing is, when you start this molecule, you have to follow your patient very carefully as far as the blood pressure lowering is concerned, because I have seen it personally in my practice. I have more than 100 patients who are on ARNI. I have noticed that if you start the patient on an OPD basis, or the patient comes with a blood pressure of 170 upon 100 and he has elevated function, you start the patient, but the evening the son calls me that the blood pressure dropped to 90 by 70. Now, this precipitous fall in hypertension, fall in the blood pressure is sometimes not easily digested by the patient, firstly. Secondly, you have to be very careful about the rising creatinine level. Sometimes it causes a rise in the creatinine level remarkably, especially once the patient is dehydrated, decongested, hypovolemic. In all these situations, the rise in creatinine level is much more. And thirdly, the important point is you have to keep a check on the serum potassium levels, because up to 5.5 milliequivalent per liter is acceptable, but anything beyond that value is definitely dangerous and it should be avoided. And especially if ARNIs are being given in combination with a mineralocorticoid receptor antagonist like spironolactone, the rise in potassium level can be more.
Thank you very much, sir.